All right, everybody. Sorry for the delay in getting this to you, but we're going to knock out this chapter 15. A ton of information in this chapter. Like I said, it's heavily emphasized on this next exam. In fact, about a quarter of the exam is actually based off this chapter. Primarily the procedures, right? The very detailed procedural process of intubation, of surgical crikes, of supraglottics, all the different ones and what makes them different from each other. So some of that stuff is the main stuff to kind of focus on. In this chapter, we're not going to lecture as much of the procedure of it because it's more tangible when you're actually doing it with the equipment. So the stuff that was explained to you by the proctors in the airway lab should really help kind of round out those sections of the textbook for when you are actually reading it. So let's jump right into it. And past our standard competencies. Again, remember those course objectives or chapter objectives at the start of each chapter is the key takeaways from it. So make sure that you're actually going back and looking at those when you're studying. Use that as a little study guide per chapter. All right, so we know everything, it's A, B, C for a reason. So everything is founded off of maintaining a clear and patent airway, right? Without the airway, nothing else matters, right? The only time that gets flipped on its head is if we're working a cardiac arrest, in which case we know chest compressions are top priority. For every other patient, though, it all hinges initially off of, do we have clear airway? So getting into the airway, it's obviously, we know the whole process. It's two sides of a coin, right? So everything is about getting the good stuff in and getting the bad stuff out, right? So the primary kind of initial function of your airway system is getting in the oxygen and removing the carbon dioxide, right? Everything else is going to obviously need that oxygen to stay alive. So the importance in airway management, again, it's a big cause of preventable death is improperly or failing to manage the airway. We know that. I actually have gotten contacted a couple times by lawyers that are involved in a case regarding paramedics and airway management and negative outcomes in patients. One of them was looking into the patient had suffered, I believe it was a hypoxic brain injury during their treatment, and the intubation by the paramedic was a failed intubation, and there was a delay in actually recognizing that it wasn't a successful intubation. And so they were kind of working their way backwards through what are the steps for paramedics for procedures, what are the confirmation methods that were used, and then they were going to look at the PCR for that paramedic's care of that patient and say, hey, here's kind of what we've gathered are the steps of intubation, and here's the list of ways in which you can confirm it. Your documentation did or didn't have that, right? I never actually saw the documentation, so I have no idea. But that's the stuff that they start looking at as they start reaching out to other paramedics saying, hey, what was done or what should be done in the steps of intubation, right? All the way from preparing ahead of time before the actual intubation attempt to what methods for confirmation of tube placement are there, how many should you do, which one should you do, and how often should you be reassessing, right? So it's huge implications for us. All right, so everything in our airway management, right? Remember, it's BLS before ALS, right? So simple airway maneuvers, head tilt, chin lift, jaw thrust, right? Inserting an OPA or an MPA, right? All that stuff's BLS scope of practice. That's fair game for National Registry. It's fair game for this test coming up, and it's just critical information that you're supposed to know, right? One of the kind of key characteristics of what makes a good paramedic is leadership, right? It's being able to manage the patient, know what you're doing, obviously, but then it's also you're responsible for the care of that patient, and that includes the care being provided by other people on the call, right? So if you see that the ENT is improperly managing the airway, not doing a good head tilt chin lift, not inserting the OPA properly, like that's still your responsibility, right? Even though your brain is kind of churning on getting your equipment set up and proper for your intubation attempt that's coming up, you're still responsible for making sure that everybody involved in the care of that patient is doing it properly. All right, so jumping back to some of the anatomy stuff very initially, Remember, we define everything initially as upper airway or lower airway, and that split is the vocal cords, right? So right there in the larynx. So vocal cords and up is upper airway, vocal cords down is your lower airway. Everything involved in it, in the upper airway, again, the main primary function that we talk about is warm, filtering, and humidifying that air that's coming in. Otherwise, we'd be constantly getting hypothermic, constantly be getting dehydrated just by breathing out warm, moist air, right? So that's the upper airway function. Kind of secondary function, some people will say the purpose of the upper airway is to allow for a pathway to get to the lower airway. Like, true, but again, most of the time, most textbooks, most everybody, they talk about the warm, filtering, humidifying functions for the upper airway being key. So a good image from your textbook, you should definitely have some kind of understanding of the structures, the different words for it. So remember the little punching bag at the back of your throat there is a uvula. Epiglottis, you can see there in the middle image. We obviously know that. You know, it's that flap that drops down, covers the trachea. If we chew or swallow foods, that it goes back down the esophagus. Even in the word, right, epiglottis, epiglottis, right? So the glottis, or the glottic opening, is just the space between the vocal cords. So the epiglottis, epi is on top of or above, it's above the glottis, above the glottic opening. So definitely a good one. It's not labeled on that picture, but if you just follow the curvature of the tongue back down to that epiglottis, again, remember that little divot, that little space there right below, they have the lingual tonsil labeled, but that space right below it is the vallecula, right? That's where, if we're using that Macintosh blade, that curved blade for your laryngoscope, the tip of that curved blade is going to rest right there in that vallecula. All right. So larynx, again, that's the bridge between your upper and lower airway, formed initially by the thyroid cartilage, right? So the bigger, more structural, more visible, and a lot of people, it's the Adam's apple, right? It's formed by two plates that form the laryngeal prominence, or the laryngeal V, or the V prominence. Again, it's just the more rigid structure one, right? If we start talking about manipulating the airway to assist us with intubation, right? I know Tyler referenced it in the airway lab, the backward, upward, rightward pressure, right? So doing some of that larynx or thyroid pressure, or some people say cricoid pressure, but we kind of got away from that term. But that's what we're feeling, right? We're actually going to palpate and manipulate that thyroid cartilage. All right, so there it is again. Hyoid bone, right? Remember that one is kind of that gee whiz Jeopardy question for us, where it's just the only bone in the body that doesn't directly kind of articulate with another bone in the body. Excuse me. And it just helps form some of the structure, some of the base support of the tongue, right? So below our cricoid cartilage, or the laryngeal prominence, right? Below all that cricoid cartilage is a little cricothyroid membrane. Below that's a cricoid cartilage. So we have the thyroid cartilage, cricoid cartilage, and then the cricothyroid membrane is right between them. Below that, it's the trachea and all the rings of the trachea. Now, some of the stuff that kind of remember on here, cricoid cartilage is the only fully enclosed ring, right? We talk about the rings of the trachea, but the trachea is actually more C-shaped, with the opening of that C being posterior, right? And that's where it kind of comes into contact with the esophagus and allows for a little bit more give, a little bit more flexibility. Cricoid cartilage, though, is it's a fully enclosed cartilage ring, so very much less kind of give to it. So that cricothyroid membrane, that's where, like the other day, we were practicing doing a needle cricothyrotomy, right, or surgical cric, right? That's where we're actually accessing, right? We're going to cut vertically through the skin, and then we're going to puncture through that cricoid membrane. All right, so that's what we just said. All right, so this is a good view. It's a good image to really understand and be able to kind of think about, label all the different structures that are down there. So this is us looking down the throat during intubation, right? So the darker kind of bumpy part that they're showing up top in that circle is the base of the tongue. Then the epiglottis is a flap there. We have our big white bands, the vocal cords. And then the glottic opening, again, is just that space between the vocal cords. And then some of the arytenoid cartilage, corniculate cartilage, is just some of those other kind of base structures on the bottom of the image or posterior in the throat. So again, definitely understand that that's what we're looking for, right, when we're ready to intubate. And so if you're in there and you're intubating and you see the vocal cords, right, don't let those vocal cords out of your sight, right? Have somebody hand you that ET tube so that you can feed it right through. Remember, the best way, the primary way of confirming initial tube placement is by watching that vocal cord, or watching the ET tube go through the vocal cords, right? Then we'll do our colorimetric capnography, SpO2, waveform capnography. We'll do all the other stuff later, but primarily, initially, it's, did you watch the tube go through the vocal cords, right? If that's a yes, then it's going to be kind of hard to argue if it's not a good intubation attempt, right? Trachea continues straight down, right, coming down before it branches at the carina. Remember, we watched that video in class of that doctor intubating himself, and he put the bronchoscope camera down there, and as he fed it down, you could see the rings of the trachea, and then you saw the split, right? Now remember, if we're looking at it, we're actually kind of going true proper anatomy, right? That right bronchi, right, the right main stem is a lot straighter down. The left one kind of juts out because it has to kind of give some clearance for the heart that's down there. So if we intubate too far, if one tube is a lot straighter and one tube comes out a little bit further, we know it's going to go into that right main stem, right? It's going to be very hard to accidentally push too far and get it to go to the left just because of the angle that it would have to go over on. All right, some of the rest of it, again, good textbook definitions, ventilation, oxygenation versus respiration, right? It's one that we kind of improperly use a lot. I think I brought it up in class before. Right? If we say we're counting the respiratory rate, well, the true definition of respiration is the actual process of gas exchange inside the body. So if we say the respiratory rate is 18, it's like 18 what? Gas exchange in the body, right? It's not truly kind of proper for it. It's one of the slip-ups that we all do. If we're counting somebody's breathing, right? They're breathing 18 times a minute. That's more definitionally their ventilatory rate, right? And we use that if we say we're ventilating at a rate of 1 breath every 5 to 6 seconds, right? We say it properly there when we're ventilating, but even somebody just spontaneously breathing on their own, the process, right, the mechanical process of moving the air into the body and then out of the body is ventilation. Respiration is down there in the alveolar capillary membranes where the oxygen is diffusing into the bloodstream, CO2 is diffusing out, right? That gas exchange, that gas movement is respiration. The third one on there, oxygenation, is now we have our red blood cells floating around, and it's the process of the oxygen actually binding onto the hemoglobin, onto the red blood cells. So good 3 definitions to have clear in your brain. Physical process of moving air in and out, ventilation. Again, 2 phases, inhalation, exhalation, inspiration, expiration, breathing in, breathing out, right? We know the inhalation is the more active muscular part, right? When we're taking that breath in, it's our diaphragm contracting, that muscle contracting, and it drops down and the intercostal muscles contract and it opens up that rib cage. And what it does is it creates a vacuum, right? It creates a more negative pressure internal environment compared to atmospheric air pressure. So if you create that vacuum there, it's going to pull the air into the body, right? So us breathing in is actually creating a vacuum and pulling air in, right? It's negative pressure driven. Exhalation is passive, so now we just relax, the diaphragm goes back up, intercostal muscles relax, any of the other accessory muscles that might be helping, those relax. That container gets a lot smaller, which increases the air pressure inside until eventually that pressure is higher than the atmospheric pressure and the air just goes out, right? High pressure to low pressure. Good. All right. Oxygenation, again, process of unloading oxygen molecules onto the hemoglobin, requires adequate fraction of inspired oxygen, or FiO2. It's a great concept. It's something that once we get a little bit further and we really can go into vents a little bit more, some vents will actually have an FiO2 setting, right? we know if we're putting a non-rebreather on, or if we're just attaching the BVM straight to the O2 tank, the percentage of oxygen is 100%, right? So the FiO2 is 100%. All of the air is oxygen. We know, right, too much of a good thing always is a bad thing, and so too much oxygen can actually become a bad thing, right? We'll call it hyperoxia, right? And that's just, chronic, just blasting somebody with 100% oxygen, right? It's great initially in a very critical patient where we really need to jump up that O2 levels inside their body. But once we're good, then ideally it would be better to kind of lower the amount of oxygen, right? So that we're not doing constant 100% oxygen. We don't generally have that setting just kind of normally for us in the field. And it makes sense, right? Shorter duration patient encounters, we're really less worried about the potentially longer term hyperoxia issues, right? But it can definitely come into play. You'll see it in the OR, you'll see it in the hospital a bunch. They have what are called, Venturi adapters, and that's where they'd say, okay, we're hooking it up to the 100% oxygen, but we're going to have this adapter that's going to pull in some room air or potentially even medical oxygen or medical air inside the hospital, and they'll dilute it down to an FiO2 of 50%. So 50% is high flow O2, or 100%. 50% is straight oxygen, and 50% is just medical air, so it's diluting it. It's better than just room air, right? Room air percentage of oxygen is about 22%. So we're going from 22% to 100%, right? So it's a big jump. So maybe if they know somebody needs to be on oxygen for a prolonged period of time in the hospital, maybe it's a trach intubated, sedated patient, and they're going to be ventilating that patient for a prolonged period of time. Maybe they say, we want the FiO2 to be 35%, right? 21% is normal room air, so we want to do better than just room air, but we don't want to go crazy where it's going to start causing problems for us. All right. So again, respiration, process of gas exchange. There's two kind of terms that we'll use for it. We'll say internal respiration or external respiration, and it's just where is that gas exchange happening. If it's happening in the lungs at the alveolar capillary membrane, then we say that's external respiration. Everywhere else throughout the body, all the rest of the cells throughout the body, that gas exchange we'll call internal respiration. So the only way that I kind of have helped remember it in my brain is saying external respiration is gas exchange involving the external air, right? So the external air is the air that we breathe into the lungs. So the gas exchange happening right there in the lungs is external respiration. Internal is then throughout the rest of the body. Right? All right, so pathophysiology of respiration, again, the biggest thing is recognition, right? Recognition right away that the patient needs extra help or isn't able to do it effectively themselves, or that something's actually causing some issues, right? So we know, right, various tissues and structures throughout the body are way more sensitive to what happens when they get low levels of oxygen, right? So more than 10 minutes, irreversible brain damage, right? Cardiac irritability within a minute of poor oxygen, right? So they say time is tissue, right? Time is muscle. So we know in those situations we need to get oxygen in the system very quickly and make sure that our body's actually distributing it and able to use it, right? So some of the early signs of hypoxia, again, restlessness, irritability, anxiety. Some of that stuff people say are early altered mental status changes. Right? It's not that they're altered, confused, or whatever, but they're restless, they're more irritable, something's going on, right? It's the body trying to, kind of get some energy, get some stuff going, so that hopefully, maybe that person can breathe a little bit better if we get that person up and moving a bit. Later signs, mental status starts deteriorating, right? That's, we might be getting good blood flow to the brain, but if there's not enough oxygen there, things are going to start shutting down, right? A weak pulse, cyanosis, obviously. Again, just more and more signs of hypoxia throughout the body. Obviously, low O2 sats, right? Poor, cap refill potentially. Starts to get into the perfusion side of it, which is the other aspect of it, right? So ventilation-perfusion ratio, or this VQ ratio, or VQ mismatch, right? And that's just the concept, which is really just what we got to understand. Is kind of conceptually, if we're breathing in great amounts of oxygen, but our heart's not pumping to deliver it throughout the body, we know nothing's going to happen, right? And same thing, if our heart's pumping blood around the body just fine, but we're not breathing in and out adequate amounts of oxygen, then nothing's going to work, right? So it's the two body systems, it's the respiratory system and the cardiovascular system, kind of working hand in hand to make sure that, yes, we're getting in good oxygen and we're getting out proper amounts of carbon dioxide, and we're able to actually distribute that oxygen throughout the body, right? So it's really just the play between the respiratory system and the cardiovascular system. All right, so things that can affect ventilation, right? We know there's intrinsic and extrinsic variables or factors. Intrinsic factors, things going on inside the body that's impeding ventilation, right? So infection, allergic reaction, unresponsiveness, right? If you start going a little bit altered and we know muscles start relaxing, right? We're worried about those muscles in the throat relaxing and that tongue dropping back into the airway, right? Number one airway obstruction is the tongue, right? That's why the first thing we do, head, tilt, chin lift, or jaw thrust, all that's trying to do is just lift that tongue out of the back of the throat, right? Then we put an OPA or an MPA or something, again, just trying to maintain that pathway for airflow to go in and out, right? If you think about things like allergic reaction, angioedema, and that tongue is swelling up, blocking the airway, right? That's going to affect ventilation for sure. Even if the brain is sending that signal down to the diaphragm, trying to get us to breathe, if everything is just swollen shut up there, then we know we're going to have a significantly reduced, maybe no airflow actually moving down through it. Extrinsic factors, something outside the body caused it, right? So trauma, foreign body airway obstruction. Sometimes you'll see the abbreviation FBAO, right? That's foreign body airway obstruction. It's a choking patient. Something's actually blocking the airway, right? One of the things that we can do beyond just the normal BLS Heimlich maneuver type stuff is going in with the laryngoscope blade and getting those McGill forceps, and if we see something, go in and actually pull it out, right? That's going to be the great thing if the BLS relief of choking interventions aren't working, then maybe it's visualization, and if we see something down in there, get those forceps, go and actually pull out the piece of steak or whatever it is, right? On the trauma side, we know, if tissue gets traumatically injured, whether it's blunt or penetrating, right, tissue's going to swell. Right? So if we start thinking about tissues in the neck, if there's blunt trauma to the neck, tissue's going to swell, but in the neck there's just very little geography that's there, right? So it's going to start swelling shut on us. All right, other things, the ventilatory effort is going to affect it, right? So hypo or hyperventilation, right? So hypoventilation, generally slower and shallower, so minute volume is going to go down. Hyperventilation, generally faster and deeper breathing. Our minute volume is going to go up. We're going to be getting rid of too much carbon dioxide, right? So it's very good to understand when is our body retaining carbon dioxide and when is it getting too much, right? When is minute volume going down and when is minute volume going up, right? We know us normal healthy people, we're triggered to breathe by an increasing level of carbon dioxide, right? So somebody's hyperventilating and they're getting rid of too much carbon dioxide and it's never reaching that threshold. Well, eventually the brain can be like, hey, everything's cool. We don't have too much carbon dioxide, so I don't need to breathe, right? It could be the same thing if we have an altered patient. We're getting a little bit too amped up and excited and we're ventilating too quickly, right? Ideally, we want our patient to start spontaneously breathing again if they aren't already. But us sitting there inadvertently hyperventilating that patient, we can be taking away that normal process, which is the brain waiting for that CO2 level to creep up to say, hey, let's breathe, right? So we can actually be reducing the patient's own natural desire to be breathing by us sitting there hyperventilating them too quickly. Other factors, high altitude, right? The air pressure, right? So remember, pressure versus percentage, right? Percentage of oxygen doesn't change. It's about 21% room air here in Mesa, it's about 21% of the room air on the top of Mount Everest, right? So the percentage of the stuff floating around is about the same. The issue is the air pressure. So the higher altitudes, that pressure is much lower. So even though there's still 21%, there's just much less of it, right? That pressure is lower. And if that pressure is lower, that's going to impede that diffusion, right? That pressure gradient, that diffusion of oxygen going into the bloodstream in the lungs and CO2 coming out, right? So again, it's all about pressure. All right, other things, conditions that reduce surface area, right? So the alveoli, if you think about like the little grape sacs, right? There's a whole lot of different little divots and everything. That's increasing more and more and more surface area. That's more and more sites for gas to actually dissolve into the bloodstream and CO2 to come out of the bloodstream, right? If it was just one big ball, it's actually less surface area, so there's less sites for gas exchange than if it has all those little ridges in it, right? So things like your chronic emphysema, chronic bronchitis patients, those alveolar walls weaken, right? The alveoli gets bigger, but that's actually less surface area, which means less gas exchange is actually going to be happening. One of the other things we've talked about is pulmonary edema or any fluid that starts building up in the lungs. Right? Gas doesn't dissolve well through a bunch of fluid, right? So if it's a CHF patient or submersion patient or chemical inhalation patients, right? A lot of those cause a lot of fluid shifting into the lungs, and that fluid is going to impede the amount of oxygen that's going to get into the bloodstream and impede the amount of carbon dioxide actually getting out of the bloodstream. All right, other things, hypoglycemia, right? If they start going hypoglycemic, start going altered, breathing effort starts going down, they're going to become hypoxic for sure. Infection, right? Increased metabolic needs, right? Generally, our respiratory rate goes up if somebody's dealing with a big infection, right? There's more demand for oxygen in the body, so the brain's like, cool, let's breathe faster, right? Hormone imbalance, diabetic ketoacidosis. We know they have those big, deep Kussmaul respirations. All right. Then if he said if it's not the respiratory system, then the issue is likely in the cardiovascular system, right? So in the cardiovascular system, there's only 3 issues that it could be. It could be pump, pipes, or fluid, right? Maybe the heart's not pumping that oxygenated blood around well enough. Maybe the blood vessels are too big, right? Vasodilation, right? So it's a lower blood pressure, right? That means something somewhere is not going to be getting enough blood flow and enough oxygen. Or there's just not enough fluid, right? Maybe they're bleeding out because of trauma or massive dehydration, right? So if we don't have enough blood volume, we don't have enough red blood cells to carry the oxygen, it means we're not going to be delivering it, right? So it really gets into shock, right? Shock is a breakdown in at least one of those 3 variables, pump, pipes, or fluid. All right, that's what we just said. Acid-base balance. So we've been talking about it a couple different times. Remember our normal pH for the human body, that's 7.35 to 7.45. So everything less than 7.35 is going to be acidic. Everything higher than 7.45 is going to be basic. Go back to some of the earlier lectures and hopefully some of the notes that you took when I really kind of went into the different respiratory acidosis, respiratory alkaloses, right? That stuff comes back into play here again. So first line system for dealing with pH imbalances in the body is the body's own natural buffer system, or the amount of bicarbonate that's floating around, right? If we become too acidic, right, our body will make more of that bicarbonate, and that'll raise our pH back up to a more neutral level, right? That's why one of the reasons we can come along and give somebody sodium bicarbonate, right, so that we can increase that amount of circulating bicarbonate, and that's going to, again, raise an acidic pH. It's going to raise it up to a more neutral level, right? Kind of bring us back into that happy little window that we want to be in. After that, the body can either adjust carbon dioxide levels or adjust fluid levels in the body. And so that's the body's ability to activate either the respiratory system or the kidneys, the renal system. Right? So it's much, much, much faster for the body to just say, hey, breathe faster or breathe slower, right? And then we get rid of more carbon dioxide or we retain more carbon dioxide. And that's going to shift our pH one way or another. It's much faster than the body sending that signal through the hormone channels down to the kidneys and say, hey, we need to get rid of more fluid in the entire body so that our pH moves. Or we need to retain more fluid in the entire body to move the pH, right? It's much faster to just breathe faster, breathe slower. Get rid of more carbon dioxide or retain more carbon dioxide. Remember, more carbon dioxide in the body, you should be thinking more CO2 equals more acid, right? So if we have more and more and more CO2 retention in the body, we're potentially more and more and more acidic, right? It's not the only time, but that's kind of the initial level that I want you guys to think of. The more carbon dioxide in the body, the more acidic we're going to be. All right. On the alkalosis side, again, if it's respiratory in origin, right? If it's a respiratory alkalosis, it means we're breathing too fast, we're getting rid of too much carbon dioxide, it means we're getting rid of too much of that acid, right? Again, link those two up. So respiratory alkalosis, that's going to be a hyperventilating patient, right? They're getting rid of too much carbon dioxide. Respiratory acidosis patient, you should think heroin overdose, cardiac arrest, right? We're not breathing enough, which means we're not getting rid of enough carbon dioxide, which means we're keeping more and more and more carbon dioxides, means we're going to be more and more and more acidic. All right, patient assessment with airway evaluation. Again, foundationally, it's BLS. Right? So reading through this, I'm going to kind of fly through some of these slides to get us to the ALS stuff. But if you don't know or can't identify some of this BLS stuff, then you really need to be getting on it, right? So much of this stuff, right? Every answer that you choose, you need to be choosing BLS before ALS, right? And there's only rare exceptions that we'll talk about when we get there. But I swear, 80% of my national registry test for paramedic, I was choosing BLS-based answers, right? That's the way you should be thinking. That's the way everybody wants you to be thinking, which is we're going to get through all this BLS stuff. If that manages the patient appropriately, fantastic, right? We've dealt with that patient in the least invasive means necessary, right? It's only if our BLS interventions aren't working that now it's indicated for us to make the next step and actually work on some ALS interventions, right? So recognition of adequate breathing versus inadequate breathing, right? You guys can go through these slides. You have access to them, right? The big one, they make that determination, and in kind of registry land, it holds up pretty dang true all the time. If it's adequate breathing, high flow to non-rebreather, right? If it's inadequate breathing, high flow to assist ventilations, right? So it's really making that determination, is this breathing adequate for life or inadequate for life, right? And inadequate for life doesn't have to be they're not breathing, although we know that one is inadequate breathing, right? It can also be breathing too fast or too shallow. They're cyanotic, right? They're using all those accessory muscle use, right? They're very obvious respiratory distress, right? Some of those can be indications where we kind of string enough of them together and we say, hey, you know what? This breathing is not adequate for sustained life. It means we need to get more involved, right? We need to assist ventilations, right? So these scenarios really have you get into assisting ventilations far more often and probably far more readily than, the real world, so to speak. We know that if we're looking at somebody and we're just, they're breathing, but we're not super great comfortable, we know we might try positioning in a non-rebreather and see how they respond, see what the O2 sats are, skin signs, everything else, right? We might try that and monitor before we get to bagging a patient that's still breathing somewhat on their own, right? But in registry and by the book, they want you to get to the recognition of this is not adequate for life, which means we need to get involved. We need to be more active. We need to be ventilating our patient, right? One of the biggest ones I can recommend to you, there's some possible causes and everything, is shallow respirations, right? And we know there's lots of times that somebody that we're actually looking at can be breathing shallowly, and we're not going to bag that patient, right? But we know that, right? But in here, in the textbook, in National Registry and everything, it's really, if they say shallow breathing, the answer that you choose must include positive pressure ventilation. I can't be more crystal clear about that, right? If they say shallow breathing, or other ways that they could say shallow, minimal chest rise and fall, that's saying shallow breathing. If they're saying decreased tidal volume, that means shallow breathing. A lot of times they just say shallow breathing, And that means the answer you choose must include bagging the patient, right? Typically, it'll take you from the A, B, C, and D options down to 2 options, right? If they'll give you a long-winded scenario, a bunch of information about the patient. If you see shallow breathing, immediately look at the answers, and usually there's 2 of them that'll say administer high-flow oxygen, which is saying administer non-rebreather. Those 2 are immediately out. The other 2 answers will say assist ventilations. So right away you're down to a 50-50, right? Then you can look at the rest of those answers and see what makes the most sense, right? Is the breathing rate right? Is the ventilation rate right? Is the other interventions correct? Whatever is proper at that point. So airway management, open, clear, assess, and intervene. Right? Those are your steps, right? Open the airway, clear it, assess their breathing, and then provide whatever appropriate interventions as necessary, right? Which is really making that determination based on opening the airway, suctioning if it's needed, and assessing the breathing rate. Now we can say that breathing rate and airway inability to maintain their airway is adequate for life, let's go non-rebreather. Or inadequate for life, let's go BVM, right? Nasal cannulas don't usually get pulled into these scenario questions. Certainly not nearly as often as we actually probably use them in the field. Usually it's the determination, are we going to do non-rebreather, or are we going to do BVM, right? And it's really, again, the picture that they paint: hypoxic, cyanotic, shallow breathing, inadequate, bag 'em, versus breathing 18 times a minute, good rise and fall of the chest, SpO2 96%, non-rebreather. Right? There's some deviations, and especially with AHA when we get further into ACLS, where we'll kind of add in a couple other things to think about. But right now, very much I want you kind of thinking non-rebreather or BVM. Right? And if that BLS bagging isn't working, that's where we'll make that next step to supraglottics or intubation or whatever the case may be. There it goes. There's some other signs of inadequate breathing. Again, definitely make sure that these lists are kind of clear in your head. One of them, orthopnea, right? The second little bullet point there. Orthopnea is positional difficulty breathing, right? Usually what you should think of, it's the CHF pulmonary edema patient. It's that patient that sleeps in bed every night with 15 pillows holding them up, and they actually sleep upright. Or they sleep every night in the recliner, right? Not because that's the station that you guys are at. Not that you fell asleep in the recliner accidentally. It's people that intentionally sleep there, because if they lay down, that pulmonary edema kind of spreads over their entire lung field, right? It makes it more difficult to breathe. So they start sleeping upright, so that gravity, all that pulmonary edema at least goes to the bases of their lungs, makes it a little bit easier to breathe, right? So orthopnea is positional difficulty breathing. And the position is, you lay them down, it's harder for them to breathe, right? So keep those patients sitting upright. Other signs for an adult: fewer than 12, faster than 20, right? Faster than 20, yes, with a caveat. You should really start looking at why are they breathing so quickly. It might be they're breathing faster than 20 because it's Kussmaul respirations because they're in DKA, right? In those patients, they're breathing too fast, but that's a compensatory mechanism of the body. We don't want to take that away, right? Or they're dealing with an infection. They're breathing adequately, they're dealing with an infection, so they're breathing a little bit too quickly, right? It's just the breathing is a little bit too quickly, but it's understanding it's not a negative thing. It's actually the body is trying to help itself, right? So when it's too fast, you got to say yes, but why, right? All right. Paradoxical motion, right? One side of the chest moves more than the other side of the chest, right? Pulsus paradoxus, right? So you take a deep breath in and your systolic blood pressure drops, right? It's easier when you have like a arterial blood pressure monitor, right? Which we don't, obviously, but in the hospital, they take a breath in, blood pressure drops. Breathe out, blood pressure comes back up, right? Can be a sign of like cardiac tamponade that we'll talk about later on down the road. But if you take that breath in, it increases the intrathoracic pressure, right? So it squeezes on the heart more. If you squeeze on the heart more, it's going to try to pump, but not as well, so that blood pressure is going to drop, right? All right, other things, again, ask about when it started, what triggered it, how long has it been going on for, any other symptoms that they're having, right? And that's just saying, okay, is this, really we're trying to determine, is this a difficulty breathing patient, like a asthma exacerbation, or is the chief complaint difficulty breathing, but they're actually in heart failure because of an MI? And we actually have a truly cardiac chest pain patient, even though the primary complaint that they have is difficulty breathing, right? We have to treat the chest pain. We have to treat the cardiac issue going on. Or we get called for difficulty breathing, but then we identify that it's actually allergic reaction based, right? Well, we need to treat the allergic reaction, right? Treat that, difficulty breathing should resolve. So it's really taking a look through and really just keeping a wide lens of your patient assessment and really working on that differential diagnosis, right? If your mind kind of is thinking through protocols, right, then we're going to assess our patient properly, really work down to a differential where it's like, I think this is what's going on with my patient. Then you can kick over to whatever protocol you have that actually applies to that. It's not that I'm dispatched to difficulty breathing, and then you get there and find out, or all you're thinking is difficulty breathing and use aspirin, or sorry, not aspirin, albuterol, Atrovent, high flow 2, maybe a steroid, right? And you completely missed all of the signs that it was actually because they were having an active MI, right? And you now have completed the patient completely inappropriately for what's actually going on with them. All right, evaluate your protective reflexes. Again, coughing, sneezing, gagging, the gag reflex. So one of them that they say, if somebody is out of it, or apparently out of it, laying there, if you just brush their eyelashes, right, very gently brush their eyelashes. If there's any sort of, twitching, kind of blinking effort, right, the muscle effort that it takes there is tied in very readily that the muscle effort of a gag reflex is likely going to be there, right? So if you flick their eyelashes just a little bit and their eyes kind of twitch a little bit, they probably still have an intact gag reflex. All right, breathing, respiratory patterns. Again, definitely memorize these. Right? You can kind of read through the explanations and kind of talk through some of them, but you definitely have to recognize these based on generally the description, right? So please memorize that. I promise you'll see it again. All right, breath sounds should be clear and equal. Should be bilaterally ready to go. So again, we're going to compare side to side. So if we're listening to upper breath sounds on the right side, the next spot we're going to be listening to is upper breath sounds on the left side, right? We want to compare equal lung fields, right? It's not that we're going to listen to top, listen to bottom, then listen to top and say, was that the same as that? Was that the same as that, right? Compare side to side, right? So upper, upper, lower, lower, right? A lot of the times they'll say listening to breath sounds on the back is easier to hear, right? Start thinking generally there's a lot less tissue, a lot less interference of structures on your back versus, the more muscle mass and stuff going on the front. All right. So these breath sounds, in terms of tracheal breath sounds or bronchial breath sounds, I'll be honest, are not terms that come up a ton. I don't hear them used very often beyond this chapter. Or the respiratory emergencies chapter, they'll probably come up on. I think with the amount of material in this chapter alone, I think there's bigger fish for you to fry, but maybe working on those definitions can be a great thing, just maybe later on in the program. All right, duration of breathing, right? So that I to E ratio, right, is normal inhalation to exhalation, right? So it's 1 second to 2 seconds, right? So most of us breathe, we breathe in for a second and we breathe out for 2 seconds, right? We breathe in for a second, we breathe out for 2 seconds, right? That inhalation of breathing over 1 second is what we kind of naturally do. That's why when we ventilate, we're going to squeeze that BVM over 1 second, right? We're trying to mimic natural breathing, right? Breathe in nice and gently over 1 second, right? We don't want to ventilate our patient where it's like, there's all your air, right? It's bad for lots of reasons, and it's not what the body normally does, right? So breathing in over 1 second or ventilating over 1 second is ideal. Exhalation's a little bit longer just because it's that passive relaxation phase in the body. All right. Yeah, so other abnormal breath sounds, definitely, again, critical ones that you got to get in your mind. Stridor, loud, high-pitched, almost like a high-pitched wheezing, but wheezing is a different one. But loud, high-pitched, heard during inspiration, that's upper airway, right? It's upper airway constriction, right? Maybe it's allergic reaction, maybe it's blockage, something's going on, but it's an upper airway constriction. It's an upper airway breath sound that we're hearing. All of your others, lower airway, right? Stridor is upper. Wheezing, we know, asthma, it's the bronchoconstriction. Rhonchi, they might say a low-pitched, rattling, I say kind of junky sound. You might think about that one with maybe a pneumonia patient. Crackles or rails is the other term. That's your fluid bubbling pulmonary edema. Right? So if you think about putting a straw into a glass of water and blowing bubbles through it, that's the crackles or rails breath sounds. All right, pulse oximetry. I hope to hell you know what it is. All right, so read through this stuff. Again, you guys have it. You go back to the textbook stuff, right? Don't just gloss over it and be like, yeah, I use pulse ox all the time. I know about it, right? Make sure you remember some of those things that can give erroneous readings, right? Or when might that pulse ox number might not be accurate, right? So still read this. I'm not going to beat up on the lecture right now with it, but I expect you to be able to kind of work our way through that, right? And remembering that in pulse oximetry, all it's doing is measuring the percentage of hemoglobin saturated. Now the assumption that we're making is that it's saturated with oxygen and that we're actually giving ourselves a sense of how much oxygen is actually in the system. But remember, if the hemoglobin's bound with other stuff, if it's saturated with other stuff like carbon monoxide, then our pulse oximetry is good. All it's going to see is that the hemoglobin's saturated, right? So those carbon monoxide poisoning patients, they might have an SpO2 of 100%, but all that hemoglobin is bound up with carbon monoxide, right? We're not actually circulating any oxygen through, right? So again, just that one kind of extra caveat, and carbon monoxide is the big one. They do have CO oximeters, right? Just like we have thinking that it's oxygen, those actually specifically measure that it's carbon monoxide. All right, peak expiratory flow, measured to evaluate bronchoconstriction, right? Asthmatics, emphysema patients, chronic bronchitis. It's how much kind of strength and muscular effort can they breathe out with. And it's a little sensor gauge that actually will measure that. Perform 3 times to take the best rate. It's certainly not something that we even have or carry, to my knowledge. It could be something, though, conceptually, if you were thinking about how it could apply in a pre-hospital setting. It could be, okay, breathe through this when we know that it looks like they're having that asthma exacerbation, and we can get a reading. And say, okay, your peak expiratory flow is this. Now we're going to give them the albuterol adjuvant treatment, and now have them do the peak expiratory flow again, and say, oh, it was here, now it's here, right? That's better. Right? We're moving in the right direction, right? Generally, though, you see it most often in some of the kind of primary care. They're evaluating their patient that they know has COPD. They're just evaluating them year after year after year to kind of see, is their condition deteriorating? Is their condition responding to treatment, staying the same, not changing year over year? But again, it could be a very helpful tool that can give us some critical information, objective information, that their condition is actually improving, as opposed to the patient just saying, I'm feeling better, right? That's subjective. If we can say their peak expiratory flow was this, and now it's this, right? That's better, right? We know that. Arterial blood gas analysis. You can go back to the notes from kind of earlier in class when I've gone through that. End-tidal carbon dioxide assessment, right? Again, detects carbon dioxide in exhale air. It's great. It's not used enough, right? I can't get on you guys enough to use it more often. There's a couple different types: colorimetric, digital, and waveform, right? Colorimetric, you can think about that little adapter piece that we put on our ET tube after intubation, right? the paper starts out purple, right? That little paper that's inside the adapter will turn yellow in the presence of carbon dioxide, right? So if we intubate somebody and we're bagging air in, air starts coming back out. If that paper goes from purple to yellow, then that's great. That means carbon dioxide coming back out. It means we're in the trachea, right? We're not going to get carbon dioxide coming back out of the esophagus, right? It's just not going to happen. So it's one way to say, yep, our ET tube's in the trachea because carbon dioxide's coming back out. So the little phrase for that one is gold is good, right? So it's all about measuring carbon dioxide, right? So there it is in that one, right? Again, it says reading after 6 to 8 positive pressure breaths, but it changes very quickly, right? And once it changes, that's it. Like, it's not going to serve any more purpose or benefit. So take it off, right? It'll look silly to just kind of leave it there. Take it off. Capnometer is just giving you a numeric reading, right? So it's giving you the breaths per minute that the little pressure thing is sensing. You know, how many times is air going through, right? So it'll actually tell you what your ventilation rate is, and it'll give us our end-tidal CO2 reading. So again, we're going to be ventilating, again, to maintain that reading between 35 and 45, right? So if we're ventilating too quickly, which is more than likely what's going to happen, we're ventilating too quickly, we're hyperventilating them, we're going to be breathing off too much carbon dioxide, so that end-tidal carbon dioxide is going to be going lower and lower and lower, right? So we need to slow down. If we see that, we looked over and we're like, oh crap, end-tidal CO2 is 15, right? It's way too low. Let's slow down our breathing. That number will start creeping back up, right? Get it back into that 35 to 45 range. If we're not breathing fast enough, the patient's retaining more carbon dioxide, which means more is coming out each time they are breathing out. They're just breathing out less often. So we look over, we're like, hey, end-tidal CO2 is 60, right? We need to pick up the pace on our breathing a little bit, right? So we still have the kind of BLS numbers that you have to know: one breath every 5 to 6 seconds for an adult. For an infant or a child, one breath every 3 to 5 seconds, right? Those ventilation rates should put us into that 35 to 45 end-tidal CO2 range, right? But we're always going to be adapting our ventilation rate to maintain end-tidal in that range. All right. Waveform capnography will actually give us waveform like that. There's two types, right? One of them is a little nasal cannula type adapter. That's for your spontaneously breathing patients. It can tell us certain information. The other one, the one on the right picture there, is for an adapter placed on an ET tube, right? So that's the best. It's considered the gold standard of continual monitoring of tube placement, right? Remember, very initially it's watching the tube pass through the vocal cords, but then it's continuing to get carbon dioxide readings coming through that waveform capnography. So these are great because it shows us what that expiration actually looks like, and it gives us that end-tidal carbon dioxide reading. So in terms of the little A, B, C, D, E on this picture, D, right, if you just followed it all the way over to that left side, right, that's the end-tidal, right, the end of the tide, right? If you think about like the tide of an ocean, right, A, B, C, D, and E, that's the tide, right? So end-tidal, right, is the end of the tide. That's D on that graph before it drops back out. So remember, it's carbon dioxide monitoring, so that's the exhalation, right? So D to E is the patient breathing in. Because if I'm breathing in, that means no carbon dioxide is hitting the adapter, right? Which means we're not going to measure any carbon dioxide. So we breathe in, that's D to E, and then we start breathing out, right? A, but mostly B and C, right? B and C is the initial boof of carbon dioxide. As we start breathing out, that sensor was not reading any carbon dioxide, and now bam, it's reading carbon dioxide. So it spikes up really quickly. Right? But we know we breathe out for a couple seconds, so we breathe out, right? So big spike up in carbon dioxide, and then we continue breathing out until we pause and take a breath in, right? So we breathe out, breathe in, right? And so it's just a constant up and down, right? You see that waveform continue going, and we're in a good position, right? We know that ET tube is properly placed because we're still getting proper carbon dioxide readings coming out. Some of them that they talk about, we can actually get into different waveforms, right? Person's breathing too fast or breathing too slow, right? So A there on it. You can see where 50 is on the graph, so our end-tidal CO2 level is way above 50, right? So we're breathing too slow, right? We're ventilating the person too slow, so we need to pick up the pace a little bit. In B, we're hyperventilating the patient. We're breathing too fast, right? So each one of those bumps is the exhalation. So the only way we get the exhalation is if we're providing the inhalation, right? So inhalation, exhalation, there's a lot of them, right? And you can see, again, if 50 is way up there, we're pretty dang low, right? On the monitor, it'll actually also give us that number for your end-tidal CO2. So in the situation of B, we need to slow down our breathing. C, sometimes you'll see, you'll hear people say a shark fin type appearance, right? If you think about like the fin of a shark over the ocean, where instead of our nice quick uptick for the wave, and then it flattens out and goes down, in C, it's a more of a gradual upswing, right? Those are generally your bronchoconstriction asthma patients will look like C, right? The issue is they're having a hard time getting the air out. So instead of a nice big burst of carbon dioxide that hits the sensor and spikes it up pretty quickly, they're breathing out, but it's harder. So it's a more gradual increase in carbon dioxide, and then they breathe in. A more gradual increase in carbon dioxide, and they breathe in. So it kind of flattens out that waveform as opposed to the bigger, almost more rectangular shape. In D, that would be somebody that's rebreathing oxygen potentially, where you'd see the base of that is continuing to stay elevated, right? It's rising up. It means they're rebreathing, right? It means the CO2 is staying in their system. If you see that, that's not good, right? That means the sensor is not reading any carbon dioxide. So if it's an intubated patient, that tube might have come out, right? And that's why we're not reading any carbon dioxide. Something might be blocking the tube, right? Maybe we need to do suctioning down the ET tube, right? So again, if you look over at that, just like a flat line on the monitor, you're dead. A flat line on carbon dioxide monitoring is very, very concerning. You got to really rapidly figure out what's going on, right? All right. One of the great things we can use End-tidal for is during CPR, right? Put your end-tidal carbon dioxide monitoring, right? If carbon dioxide is, every time we're doing chest compressions, our CO2 is minimally coming out, like less than 10, right? So if we're getting an end-tidal of 5, that means our chest compressions suck, right? So if you're getting 10 or better for chest compression, so every time we're squeezing on that chest, we're forcing some of the carbon dioxide out, right? If it's 10 or better, that means we're getting good quality chest compressions. It's kind of a weird thing, but it's a super helpful little tool to measure how effective our CPR is doing, right? We know we're providing oxygen into the body, and we're trying to circulate that oxygen throughout the body, but the amount of carbon dioxide coming back out is telling us how well are we actually doing? How well are we actually distributing that oxygen throughout the body? The body's actually using it to make the carbon dioxide as the byproduct, and then to actually get it out of the system, right? So an end-tidal carbon dioxide greater than 10 is signs of a good quality chest compressions. If, when we're working the code, all of a sudden we look over and we were getting 10 on end-tidal, and now you look at end-tidal of 60, 99 times, I bet you your next pulse check, you're gonna have a pulse back. All right. Airway management, again, BLS positioning, right, is working through, you know, when do we put somebody in the rescue position? When do we need to do head tilt chin lift? What are the indications, contraindications for head tilt chin lift and jaw thrust maneuvers? Right? Again, all BLS stuff. You guys super responsible for this knowledge. There'll definitely be BLS-based questions on the exam. I just guarantee it. Again, tongue jaw lift. Again, you guys should be able to read through these pretty readily. Suctioning, right? A lot of different types of suction units out there. The biggest one is not putting the suction catheter further than you can see, right? If you go past the base of the tongue, right, where you can't see it anymore, you hit that base of the tongue or anything, you're likely going to stimulate gag reflex, vomiting, aspiration, right? Really bad. So We're going to suction only as far as we can see. And then you can read again some of the different types of suction units and issues between them. But then for an adult, we're going to suction for no more than 15 seconds. For a child, no more than 10 seconds. And for an infant, no more than 5 seconds. Again, more sensitive, more likely to cause issues the younger we go. All right, Yonkauer catheters or rigid tip catheters are the ones on the left-hand side. They're great, they're nice, they work really well. Whistle tip catheter or flexible suction catheters, the one on the right-hand side. Those are great. You can actually feed those down the ET tube. If as you're bagging an intubated patient, you know that tube's good, you see junk start coming up that ET tube, right? We can feed one of those flexible suction catheters down the ET tube to clear it out. And they're a lot smaller of an opening, so it's easier to clog them than the bigger, rigid Yonkauer catheters. But again, it's a great option. All right, so there you go. Suctioning for adult, child, and infant, 15, 10, and 5 seconds. And it's also something, if after 15 seconds of suctioning an adult, you look in there and there's still stuff, we can't just keep suctioning forever and ever and ever, right? If they're actively bleeding or something's happening. So if after 15 seconds there's still stuff in there, we have to bag that patient, right? Because we know if all that stuff's in there, they're not getting oxygen, right? So we'll do 15 seconds of suctioning, then we'll ventilate for 2 minutes. Then we can suction again for 15 seconds and ventilate for 2 minutes. And so we'll just keep alternating, right? If suctioning isn't clearing it, they're continuing to have issues, right? So suction for 15 seconds, ventilate for 2 minutes. Suction for 15 seconds, ventilate for 2 minutes. All right. Measurement-wise, kind of like an OPA, right? You can measure from the mouth to the earlobe, right? Just that's how far we would insert an OPA, which is just to get to the base of the tongue, right? It's the same distance we're going to use for the rigid tip suction catheter, right? Or just when we're opening it up and taking a look inside, we're actually only inserting it as far as we can see. Again, remember, you're going to stimulate that gag reflex, they're going to vomit on you. Now we're worried about aspiration. All right, OPAs and NPAs, again, unresponsive patients, no gag reflex. You can put them in people that are still spontaneously breathing, right? Sometimes in the ER you'll see them, they have alcoholic patient that's really out of it but still breathing spontaneously, and they're sitting there snoring in the ER. Sometimes you'll see them, they'll go and they're out of it enough that they don't have a gag reflex, and they'll put an OPA in just to get that tongue out of the back of the throat. Right? Measurement wise, you should measure again, corner of the mouth to the earlobe. Right? We don't do what they're showing in the picture anymore, which is the OPA being inserted fully upright and the 180-degree turn. Right? That's what it used to be. It's what some of you undoubtedly learned. That's what I learned when I went through EMT school, was you insert the OPA completely upright and then rotate 180 degrees down to the base of the tongue. Now they say insert it sideways and just rotate the 90, right? Less likely to cause some trauma to the soft palate and the hard palate on the top of the roof of the mouth. All right, so you guys can read this, sizing, everything. Again, your book should reflect it properly. I'm not sure why this slide still says it, but remember, it's a 90-degree insert and rotate the 90 degrees. Insert it sideways, rotate 90, not 180. I apologize for not just adjusting that myself in the slides. All right, NPAs, again, rubber tip, bevel towards the septum of the nose. Again, absolutely just no facial head trauma concerns, right? Same thing if we're going to do a nasogastric tube or a nasal intubation. It's contraindicated if there's any sort of head trauma, right? The concern is there's a basilar skull fracture, and when we insert it into the nose, that the tube actually goes up into the cranial vault as opposed to down to the oropharynx. All right, so contraindications, again, the main one is no head trauma, facial trauma, but just, they'll say some facial trauma, skull fracture, any sort of head trauma, just assume that there's fractures in there and we don't want to put anything in their nose. All right, you guys can read all that. Measuring, nose to earlobe, for sure. Airway obstruction causes, again, lots of different ones. Foreign bodies, the tongue is the main airway obstruction. Laryngeal edema or laryngeal spasm, right? Or laryngospasm. Right? So if you think about a drowning patient, right? They start relaxing and water hits their vocal cords, right? It'll spasm, they'll snap shut. Right? It's a self-protective method of trying to keep stuff out of the lungs that shouldn't be there. But if those vocal cords are snapped shut, that means we can't get any oxygen in and carbon dioxide out, right? So hopefully those start relaxing once we're there and able to actually manage it. Again, tongue, number one cause of airway obstruction. Right. All right, foreign body airway obstruction, again, middle-aged, older adults potentially. Dentures can be the foreign body that's obstructing. Right? Alcoholic patients, maybe they're out of it and choke on something. Stridor, again, is upper airway constriction or upper airway blockage, right? So it's the one breath sound that we actually say is an upper airway issue. Laryngospasm, laryngeal edema, right? So epiglottitis, anaphylaxis, inhalation injuries, right? Start swelling that tissue up in the throat, and that's going to be your laryngeal edema. And not something that we can quickly overcome. So if it's really, really bad, that's why it might be one of the indications why we might have to bypass that airway for a needle or a surgical crike. All right, maybe relieved by muscle relaxants, right? We start talking about those vocal cords snapping shut, right? That's the muscles that are there are holding it closed. So if we're doing like RSI, we're giving a paralytic, right? It paralyzes those muscles. Those muscles just relax and they're open up, and then we can intubate the patient or whatever, may be the case. Laryngeal injury, fracture the larynx, right? And going to make it much more difficult to bag, right? We're potentially going to be bagging, and some of that air is actually going to be going out into the tissue, right? Just because there's a fracture to that larynx. Aspiration increases mortality, can obstruct the airway, destroys bronchiolar tissue, introduces pathogens into the lungs. Again, we just know there's stuff down in the lungs that shouldn't be there anymore. We can suction to the extent that we can hopefully suction, but huge risk of infection and sepsis, and all that stuff's just going to be getting in the way of us trying to get oxygen into the body and carbon dioxide coming out of the body. All right, so recognition of airway obstruction, this goes back to just your classic HA BLS, right? When is it a mild versus a severe obstruction, and what do we do, right? So mild obstruction, they're still moving air. That means we're really not going to do anything. We're going to encourage them to keep coughing and to monitor them closely to make sure that they are still able to move air. And we're getting ready to do stuff, but we're not doing anything, right? And so if you have a choking patient and they're coughing, you hear the stridor, you hear whatever it is, but they're still moving air, we're not doing anything, right? It's only once it moves over to a severe obstruction, that's where it's indicated for us, right? And we actually get involved and start intervening. So they can't breathe anymore, they can't talk, they're not coughing, may grasp at their throat, turn cyanotic, make frantic movements. Cough is weak, ineffective, or absent, right? Absent mostly is what we're talking about. May still be conscious, right? But we know they're not for long. They'll go hypoxic, they'll crash out. Then, again, if they're conscious in severe obstruction, we'll actually get involved. We'll do the abdominal thrust if it's an adult or a big enough child, or we start doing the back blows for your little ones. All right, so that's severe. We start getting more involved. Once they go unresponsive, then we start doing CPR, but every time we would normally ventilate, before we ventilate, we're going to take a look inside. Right, just remember, the goal of the chest compressions in those situations is not to pump the heart's still beating. It's to try to increase that pressure to dislodge whatever that obstruction is. Then if we take a look inside and we can see it, we can scoop it out. Right? We don't do the blind finger sweep anymore. If we can't see it, then maybe what we could do is get that laryngoscope blade as if we were going to intubate, just to look down there and see if we see it. If we do, then we can go in and get it. All right. So again, go back through this stuff, but it's the BLS stuff, right? That's what I say, and those are the McGill forceps, right? So we go in there, we take a look, we see something way down there blocking it, right? We can get those forceps and go in, grab it, and pull it out, right? Maybe we still need to ventilate the patient. We're not sure. We'll kind of reevaluate the patient at that point. Maybe they weren't super out of it. And now that we cleared that obstruction, they're able to breathe and they wake back up pretty quickly. That'd be fantastic. But we'll keep evaluating and decide what we need to do at that point. All right, supplemental oxygen, right? High flow O2. Again, you should know everything possible to know about oxygen for us, right? So it's the green tanks, right? Replace the cylinder when pressure falls to 200 or lower. Again, a textbook number, right? If it deviates from your standard practice, we're like, hey, once it's 500, I change out my O2 tanks, right? 200 is by the book. We always got to go back to what the book says. That's why I'm kind of increasingly pressuring you guys on making sure that you're reading this stuff, that you're reading to comprehension, right? The goal is not, I read the book, right? It's making sure that you actually understood everything, right? And not just the kind of self-determination of what you think does or doesn't apply to the field, right? Everything in that book is fair game, scope of practice nationally, and it's the only way that as a profession we're going to keep advancing and keep progressing is by continuing to challenge ourselves, continuing to learn more, and keep growing and improving as providers. All right, that's my soapbox for the day. All right. So again, safety reminders, read this stuff about oxygen, the Borden gauge flow meter, right? Just read this stuff. You guys should really have a good understanding of this stuff, hopefully. Remember, this stuff's going to go back through your National Registry O2 admin skill sheet. For those of you that are more recent, remember that stuff from EMT school. Again, you're responsible for knowing all of those steps, right? And a lot of the procedural questions that you guys will get will be determined fully on your ability to answer the question is determined fully on, do you know the exact textbook step-by-step procedure? And if they give you a question that puts you right here on the procedure, then the question's going to ask you, what do you do next? And it's just the next thing down on that list. All right, so non-rebreathers, 90 to 100% oxygen, right? We know there's just a little bit of leakage. We don't have a full constant face-to-mask seal with non-rebreathers. So even though it's 100% oxygen coming through, we know we're getting some extra air that's kind of being pulled in. So that's why it can, be 90 to 100%. Nasal cannula, again, same thing, 100% oxygen coming out of that O2 tank, but we're also breathing in a tremendous amount of room air, right? So room air is about 21% oxygen. So with nasal cannulas, the percentages that you got to know is 24 to 44% oxygen. And really that maps to kind of 1 to 6 liters per minute, right? 1 liter per minute of oxygen, we know that's very little oxygen. So most of what we're breathing in is the 21% room air. So we're only minorly increasing the percentage of oxygen that we're actually breathing in, right? We're still heavily diluted by the room air. Go up 6 liters per minute, right? That puts us into that 44% oxygen. So, double what's normal. So that's great. But again, we just know that it's not ideal in a lot of situations. Ineffective if they're not breathing. Obviously, we're not venting a person through a nasal cannula. So again, go back through those. Make sure you read them. Great table right here. 1 to 6 liters per minute gives you your 24 to 44%. Non-rebreathers, 15 liters up to 90, right? BVM, 15 liters per minute, pretty much 100%. The only time it's not 100% is if we're not maintaining a good face-to-mask seal when we're bagging the patient, right? All right, so these ones kind of go back through the information from that table. So again, should be pretty straightforward. Venturi masks or Venturi devices, sometimes you'll see them in the hospital if you've ever wondered what that little blue tube is coming off of a like non-rebreather style mask that they're wearing. It's the little adapter piece at the bottom of that blue extension piece that is, it has little holes in it that adjust how much room air is being pulled into it. So we're still feeding 100% oxygen up to the mask, but those little green and yellow and orange and white adapters are just allowing various amounts of room air to come into place. And if you look at those little, like that orange adapter that's plugged in there, if you took a look at it really close, you would see on the side of it, it might say 28%, That's telling us when you put the 100% oxygen tank through there and it pulls in its set amount of room air, that means the amount of oxygen that they're actually breathing in is 28 or 35 or 40 or whatever it is. So it's just allowing for more carefully monitoring. Again, usually longer term patients, right, that we don't want to blast with 100% oxygen for prolonged periods of time, but they need a little bit better than room air, right? So they need better than 21% oxygen, but they don't need 100. So let's put one of these adapters in there that says it's going to adjust it to give 35%, right? Some of the more advanced vents will actually have an adapter or a dial gauge or something on there that you can say, we want to give 50% oxygen. And it's plugged into the 100% oxygen tank, it's just adjusting how much room air is coming through. Tracheostomy masks, again, cover the stoma and have a strap that goes around the neck. Right? If we don't have that, or if we're trying to just figure out some way to do it, just get a little non-rebreather and you can put it right over. And it's almost kind of like blow-by oxygen for kids, but we're just kind of focusing where we're delivering that oxygen. Humidifiers, again, should be some straightforward stuff to read. It's great for longer term transports, patients that are going to be on oxygen for a long time. It's incredibly dry oxygen coming out of an O2 tank. So we know it's just going to dry out their nose, dry out their mouth, dry out everything, right? So if they're going to be on it for a while and you have the ability to hook up the humidifiers, right, the little jug of water basically that attaches to it, so it just bubbles it just pushes the oxygen through all the water, just kind of moisturizes the air. Again, can be really, really helpful for patients, especially the ones that are on it for long periods of time. All right. So ventilation, again, we've been talking about this stuff earlier. So normal ventilation, negative pressure driven, right? We create that vacuum versus we come along and we have a patient that we need to ventilate, right? That's positive pressure. We're forcing the air in, right? So us ventilating a patient is better than nothing if they need it, for sure. But we just have to understand physiologically, it's the exact opposite of what's going on with the patient. All right. One of the issues with positive pressure ventilation, and as we're bagging in there, we're increasing the pressure inside the chest cage, right? That intrathoracic pressure. And the more and more and more pressure we put in there, the more pressure starts squeezing on the aorta, squeezing on the vena cava, squeezing on the heart, right? So we start restricting the amount of blood coming back to the heart, and we're restricting the ability of that heart to fill up really nicely. It can only fill up a little bit, which means it's only going to pump out a little bit. So by us, ventilating the patient and increasing that pressure, we're going to potentially keep just bottoming that blood pressure down. All right. Other ones, right? Remember, it should be a nice, gentle squeeze of that bag over 1 second, just until we see chest rise and fall, right? It's very easy for us to overventilate too quickly and too much, right? Remember, the goal is squeeze the bag over 1 second, just far enough for us to see visible chest rise, right? And so again, visible chest rise is all we're shooting for, right? If they phrase something and said, ventilate until you see maximal chest rise, right? That's not how we phrase it, right? That would be over-ventilating somebody, right? So ventilate over 1 second, right? Which is 1 Mississippi, right? Nice and slow, just till you see chest rise, right? Anything more than that, and we're just gonna kind of overpower the system. We're gonna force some of that air down the esophagus into the stomach and cause that gastric distension. That gastric distension is bad because as that air pressure fills up in that stomach, it starts pushing that diaphragm higher and higher, which is just going to restrict the amount of space that the lungs can fill up with air. All right. So ventilating patient, again, you can go back, read through the stuff, mouth to mouth, 1, 2, or 3 person ventilations. Right, mouth-to-mouth ventilation, again, even if your mind's like, I'm never going to do that, I'm always going to have my equipment, that's true, hopefully that's your answer, but you're still responsible for knowing all this information about it. So don't gloss over any of this stuff. All right, a little bit further, BVMs, that's what they look like, hopefully you know that. Again, 100% oxygen, just depending on the face-to-mask seal that we're getting. And that's the issue, right? we've got this aspect of bagging the patient, and we've got our CE grip holding it in place, right? Both of them need to be working properly. Right? A lot of people, pretty much everybody, were taught CE grip with that left hand, and we're going to squeeze the bag with the right. My wife, she teaches ACLS, she teaches medic here at the school as well. She taught an anesthesiologist was recertifying their ACLS, and they had a conversation. She told me about it, and my mind was like, that makes freaking perfect sense, right? The squeeze of the bag part is not super difficult, right? The face to mask seal is critical, right? So he had recommended, it's not that it's required, there's nothing in the book that says you got to do it one way or the other. Completely fine to do it whatever way is working for you, but maybe try it, right? Next time you get a patient, get the opportunity, do the CE grip with your dominant hand, right? So try to flip it around. Instead of CE grip with the left hand and bagging with the right, try doing the CE grip with your right hand if that's your dominant hand, right? Stronger, you might be able to get a better face to mask seal. And then I can still squeeze the bag easily with my left hand, right? But my right hand might be stronger for that CE grip. Right? So just a recommendation, again, not required. Nothing is going to dictate that you do it one way or another. Ultimately, the only thing that matters is we're getting a good face to mask seal and ventilating the patient properly. All right. So volume of air that we're going to deliver, again, based solely off of visible chest rise, right? Again, that's what I was just saying. Squeeze the bag over 1 second just till we see chest rise and fall. Nothing else matters before that, right? That's the first thing we're looking at. Well, then we'll take a look at our SpO2 sats as we go and our end-tidal CO2 range and stuff like that. But initially, squeeze of the bag over 1 second just till we see chest rise and fall at the appropriate rate. So appropriate rate for adults, I'm going to click through some of these slides. Appropriate rates for adults, 1 breath every 5 to 6 seconds is our BLS ventilation rate. That's 10 to 12 breaths per minute. Once we get an advanced airway in place, supraglottic device or an intubation, then we know 100% of that oxygen is going to the lungs, so we'll actually slow down our ventilation rate even further. So if bagging somebody with an OPA is 1 breath every 5 to 6 seconds, once they're intubated, we'll slow it down to 1 breath every 6 to 8 seconds. So 8 to 10 breaths a minute as opposed to 10 to 12 breaths per minute. For infants and children, ventilate 1 breath every 3 to 5 seconds, which is 12 to 20 breaths a minute. Same thing, slow it down to 1 breath every 6 seconds, 1 breath every 6 to 8 seconds if they're intubated or we have an advanced airway. So again, whichever way you memorize it, make sure you got both, right? Again, just critical numbers to know. 1 breath every 5 to 6 seconds is 10 to 12 breaths per minute, right? So I always, for whatever reason, I always remembered, and I always say it first initially, 1 breath every 5 to 6 seconds, right? But maybe the test question says ventilate at a rate of 10 to 12 breaths per minute, right? You got to make sure that you know that those are the same. All right, so you guys can read your BVM stuff, right? Transport ventilators, right? All sorts of different ones, right? I'm trying to get my hands on one of AMR so I can bring in exactly what you guys would be using there if you get one. But the basic level ones are like your auto vents, where it has a dial that says give 16 breaths per minute or 18 breaths per minute or 20 breaths per minute or 10 breaths per minute. You can put it to whatever number of breaths per minute you want the vent to deliver, and religiously until the day it dies, it'll give the 14 breaths per minute that you have that dial set at, right? No exceptions, right? So the rate is on there, and then the volume of air is on there. So you can adjust it to 15 breaths per minute and 500 milliliters of air, right? 500 milliliters of air. All right. A bag mask device available in case your vent malfunctions, right? So just because we get the vent going, right, doesn't mean everything's going to be good forever, right? We always have to have all of our airway management stuff out and kind of ready to go just in case something happens. And whether it's our vent or the patient's ventilated or something's going on, right, whatever is happening, if it's not working properly, immediately revert to your BLS airway management, right? Discontinue the auto vent or whatever it is. Put the OPA back in if that makes sense for your patient, right? Not if they're intubated, obviously, but immediately just go back to BVM, right? We can troubleshoot the vent and figure out what's going on later, but we need to make sure that the vent is actually, or we need to make sure that the patient is still getting the oxygen that they need. CPAP, super non-invasive. It's great. We've talked about it a couple times, right? Talking about our CHF patients. We pulled out some of this stuff the other day, so hopefully you guys are feeling pretty good about it and understanding when we're going to be able to give it, when we're not going to be able to give it. Patients got to be alert, able to follow commands, right? They have to be breathing spontaneously enough, right? The CPAP doesn't work as a vent, right? It can't breathe for the patient, right? It's just assisting it if they are breathing or aren't breathing. Contraindications, pneumothorax, chest trauma, right? We don't want to blast a bunch of high pressure air into the chest if we know they have a pneumo, right? It's just going to make the problem worse. Bleeding, nausea, vomiting, right? You don't want them to vomit into that CPAP mask as it's blasting that air down their lungs, right? So definitely understand all these contraindications for it, when you can give it, when you cannot give it, and then how it actually works. PEEP, again, great video that Omar showed you guys in Airway Lab this week of just keeping, right, that positive end expiratory pressure is keeping that back pressure inside the lungs so that the lungs and the alveoli and everything stay nice and open and full. 5 to 10 is generally considered a great range. I think Rick talked about, Dr. Stites said we can titrate up to 10 at AMR, I believe is our policy. Double check that, don't quote me on it. And if you think you need to go beyond that, it would be a patch for orders type of situation. All right, some of the CPAPs allow you to adjust that FiO2, right, the fraction of inspired oxygen. So again, just how much airflow is actually being, or how much percentage of oxygen is actually being delivered. Some of them also let you attach on the SVN nebulizer, where you can use CPAP as a transport mechanism for delivering that albuterol atrovent. Gastric distension, we just talked about a little bit, right? Putting in too much of that air pressure into the stomach, right? It starts pushing up on that diaphragm, limits the ability of our rib cage and everything to expand nice and full. All right. If we do notice that we're filling up that stomach, then we can drop in an OG or an NG tube, right? So NG tube, nasogastric, right? So nose to stomach, right? So inserted through the nose, and the tip of it goes down into the stomach, allows you to suction off or relieve that air pressure, or potentially even, lavage out whatever stomach contents are in there that we don't want to be in there. So the measuring method would be nose to ear to xiphoid process, right? If it was an orogastric tube, mouth to ear to xiphoid process. Some of the people I think usually do around the ear, and it's going to put you pretty dang close. But go back to whichever one your book says, whether it's just mouth to ear to xiphoid or mouth around the ear to xiphoid. And the big thing is you got to then kind of clamp and hold on to it, right? So once you measure your proper distance, then you got to hold on to that, and you're going to feed it in until you reach that distance, right? First OG tube that I placed, like halfway through I had to stop and take the tube out because I measured everything properly. Then I was like, great, okay, and I started feeding it in. I realized I didn't keep my fingers on the distance that I measured it to, right? So I was like halfway in, I was like, crap, like I had to pull it back out, get another one, remeasure it, hold it, and then feed it in just until I reached that limit that I needed it to be at. All right. Great thing, again, post-intubation, right? We've been BLS bagging our patient. We know some of that air is going down to the stomach. So once we intubate that patient, again, an OG tube is a great thing. It should be damn near considered standard practice. You should do an OG tube after every intubation. We really don't see it done a lot, or at least I never saw it done a lot pre-hospitally for all the intubations that I was around. But again, just a great thing to do. Because you know any of that air that's down there, it's working against you, right? So don't just miraculously stop and feel great just because we got a successful intubation tube. We still have to think through what's needed for our patient, what's best, what's next. And so dropping that OG tube down into the stomach and relieving that air pressure is only going to help you. All right, laryngectomy, surgical removal right? Ectomy is removal, so laryngectomy, removal of the larynx. Can be total or partial, right? That's just whether or not a patient can breathe through a stoma in their trach, or whether they can't, right? And they can still breathe through their mouth and nose. So definitely understanding if they can't breathe through their mouth or nose at all, then everything hinges on that stoma that's there, right? And if we're going to bag that patient, right, you can get your BVM and the little like infant child mask, and you could put that just over the stoma, and you could ventilate that way. If they can still breathe through their mouth and nose, then you could potentially cover that hole and bag normally, right? Or cover their mouth and nose, but that's going to look weird, and then bag through their stoma. All right, suctioning of a stoma or tracheostomy tube. Again, we know some of those get kind of built up with those mucus plugs pretty readily. Limit suctioning to 10 seconds, right? And so definitely something that will need to be suctioned undoubtedly regularly. A great kind of test-taking strategy or really test-taking strategy, test-taking tip for you is if it doesn't say that there's mucus or secretions or something like that, then the answer is not suction, right? Even though we know a lot of those patients do need it, right? If the question itself, the words that are on that piece of paper, if it doesn't say explicitly that there's secretions or there's mucus or there's something there, then the answer is not to suction it, right? They have to tell you something's there for you to say, cool, I need to suction it. Right? So it's just a little test-taking tip for you. All right. Dental appliances, the determination for whether we're going to take them in or leave them out. We know it's a definite risk of airway obstruction. Really, it's just if they're stable and everything's in place and not moving, then leave them there, right? If they're loose, if they're dislodged, anything like that, now or whether we identify it later, if they're loose, it's potentially going to block the airway, then we'll take them out. All right, facial trauma. Severe swelling and bleeding in the airway may be present. So again, we said suction is needed, and we might be doing that suction, ventilate, suction, ventilate, suction, ventilate. Right? Suction for 15 seconds, ventilate for 2 minutes because we got to get oxygen in. And then we can go back, we can suction for 15 seconds again, and then we can ventilate for 2 minutes. Right? So we might just keep going back and forth with that. All right. Good. To the extent possible, right? We don't want to do the head tilt chin lift if we're worried about facial head trauma. We try to protect that C-spine if we can. Ultimately, though, if we're unable to ventilate the patient and we can't get it with that jaw thrust maneuver, then unfortunately we're in that situation potentially of life over limb, right? Maybe we do that head tilt chin lift when we really don't want to, but we're not able to manage the airway, right? Airway still takes top precedent, right? If there's severe facial trauma, we can't ventilate effectively, we can't intubate the patient, right? Everything's just mush when we're in there. Then it's one of the indications that we might have for going and performing a surgical cricothyrotomy. Sorry. Advanced airway management, again, getting into all of our intubations and stuff like that. The reasons why we do it is we can't maintain a patent airway, or the patient can't do it, and we're unable to oxygenate and ventilate the patient with less invasive means, right? So if an OPA and BVM's working, it's working, great, just keep doing that, right? It's only if it's not working, something's going on, we're not quite happy with the situation, we're worried about vomiting and aspiration, then we can take that next step to a more advanced airway. But we don't just blindly jump to, hey, I'm a paramedic now, this person needs help, I'm going to intubate them. Like, no, we're going to insert an OPA, we're going to assist ventilations, 1 breath every 5 to 6 seconds, evaluate our patient, and see if we need to do anything else at that point. Right? BLS before ALS. Predicting the difficult airway, I was sitting in there a lot when Tyler was going through this, so this part should be matched pretty much to a T. The Lemon mnemonic, the 3-3-2, right, for space of the mouth, chin to hyoid bone, and then hyoid bone down to your thyroid notch, right? So 3-3-2 is kind of the Anything less than any of those, we anticipate a little bit more of a difficult intubation attempt. It can be one thing, same thing with Mallampati here, right? If all of these things are saying, look, everything I'm seeing is telling me it might be a more difficult intubation attempt, then it factors into your decision of, do I need to intubate this patient or not, right? If I'm really anticipating a difficult intubation and my BLS airway management is working pretty dang well, then great, I'm just going to keep doing the BLS, right? If BLS isn't working well and all these assessments say, hey, it's probably going to be a relatively easy one, then great, go for it. Ultimately, though, if they need to be intubated, then they need to be intubated. We're going to have to do our best, whether we think it's going to be difficult or not. We're just anticipating, if we know going into it that this is potentially going to be a more difficult intubation. There's some good visuals there of ability or inability to see stuff. But if we know, or we really anticipate it's going to be a more difficult intubation, then let's have our backup airways and things ready to go for it. All right, positioning of the head and neck, sniffing position, right? It's not massively hyperextended back or crunched down or anything like that. Just, hey, what's that smell, right? Just sniffing position, right? So it's same thing adults and kids. Kids, to get the sniffing position, sometimes we'll say put some padding, a little blanket or pillow or something underneath their shoulder blades, right? Just lifts up their chest and it kind of naturally will put them into that sniffing position. All right. So endotracheal intubation is just intubating into the trachea, right? And that's what we say all the time, endotracheal intubation. You can specify orotracheal intubation as we're intubating into the trachea through the mouth. Oro is mouth. Or nasotracheal intubation, right? So if there was a test question that said, what is it called when you intubate somebody through the mouth? And one of the answers is endotracheal intubation, one of them is orotracheal intubation. Orotracheal intubation would be the better answer of the two. Endotracheal is a little bit non-specific. All it's saying is we're intubating into the trachea. It didn't tell us how we got there, right? So advantages, disadvantages. Again, you guys got this stuff pretty dang well in the airway lab, so I'm going to trust that you can really read through this stuff and kind of link it to your experience in the airway lab. But again, procedural, so much of this stuff is going to come down to procedure and understanding the things that we're using. So all of our ET tubes have that 15 millimeter, or sometimes it's 15-22 millimeter adapter. They're all the same size. It's the same size that all of your vent tubing, same size that every BVM is going to attach to. Everybody is making them the same size. The pilot balloon, right, filling up the cuff at the end of the ET tube, 5 to 10 milliliters of air is going to be the amount to fill it up, right? It depends on the size of the tube. Bigger tubes, more like 10 milliliters. Smaller little tubes with a little cuff, more like 5 milliliters, right? And then there's the open end, and then, or Murphy's eye, right, at the end of the ET tube that actually goes down into the trachea. There's also a little other hole on the side right there. And that's just saying if we have a hole on the bottom and a hole on the side, right, if junk and stuff covers that one, well, there's still the other hole that we can ventilate air through. Right, so it's just a little backup just in case the end of the ET tube gets clogged over with some stuff. All right. So here's your ranges in size, 2.5 to 9 millimeters. That's the inside diameter of the tube. And then 12 to 32 centimeters in length. They're all pretty much look the same, right? Some, especially some of the smaller ones, don't have your centimeter markings. Some do, right? Smaller ones for us don't have the little balloon cuff at the bottom. Some do, right? But all of them have that 15-22 millimeter adapter where we hook the BVM up to, right? All of them have an opening on the other end for us to deliver the oxygen. Right? So the stylets that are inside the ET tube, again, help kind of give some shape to it. Some people, I know Tyler was telling you, some people do just a nice swooping one. Other people do a really exaggerated, hockey stick type shape. Again, it's whatever you get comfortable with and whatever you think is going to help you get a successful tube. Right. The entire goal is just how do we maximize the chances that we're going to be successful on this intubation. The end of the stylet should be at least a ½ inch inside the ET tube, right? You don't want the tube and then the big stylet sticking out the end of it, poking the lungs and stuff like that as we're inserting it. So make sure that the stylet is at least a 1/2 inch inside the ET tube. All right. Pediatric patients, again, no cuffs on them usually, right? At least most places pre-hospitally carrying ET tubes. The pediatric ones, we don't have cuffs on them. Go to Cardin's and Phoenix Children's and stuff like that. They probably have cuffed ones. They may or may not inflate it, right? It'd be a great question to ask the ER docs when you're there. Like, hey, why would you use a ET tube with a cuff for this little kid versus without a cuff? Or if you notice that they used one without a cuff and they didn't inflate it, great question to ask. Like, hey, what factors weigh in on your decision to inflate that cuff or not inflate that cuff on the pediatric one? On the adult ones, we inflate the cuff. Like, there's not a chance of going otherwise on that. All right, laryngoscope blades and handles. So again, straight blades are your Miller blades. I've literally never heard anybody say it's a Wisconsin blade. Miller blades are your straight blades. I remember the L in Miller is straight versus the C in Macintosh is going to be your curved blade. Right? So your straight blades, again, go underneath the epiglottis and they lift everything up and out of the way. Right? Your curved blades or the Macintosh blades, the tip of that just follows the tongue around and gets into the vallecula, which is above the epiglottis, and then it lifts everything up with it. Right? So Miller blade under the epiglottis and up, curved blade into the vallecula, and it's going to lift the epiglottis with it. So blade sizes, 0 to 4, right? The lower the number, the smaller the size, right? Pediatric patients, it's the only one that really gets kind of mandated as a recommendation. With your little kids, Miller blade, right? Could you do it with a Mac? Potentially, yes, but really you should put it in your head, little kids, Miller blade. Adults, Mac or Miller, personal preference, whatever you think is going to be successful for you. You should really, again, as you're preparing to intubate, you're going to have all of your equipment out, right? So if you're thinking, hey, this adult, I'm going to try a 7.5 ET tube, then you should have an 8.0 and a 7.0, right? One size larger and one size smaller ready to go. So when you get in there and you see the anatomy and go, hey, this is bigger than I thought, let me get that larger tube, right? Or smaller than I thought, let me get the smaller tube. You should also have McGill forceps, just in case we didn't know that this was actually a choking patient. And you get in there and you see a piece of steak down there. Like, go in and get it out. Right? You should have some supraglottic airways, right? Some backup systems in place. You should have, again, your colorimetric capnography, your waveform capnography devices ready to go. Right? You should have the patient on the monitor where somebody is watching it and letting you know, hey, they're going too bradycardic, which is one of the side effects that can happen during the process of intubation. Or they're going too far hypoxic, let's stop that intubation. Right? Remember, one of the other big requirement steps is that from squeeze of the bag to squeeze of the bag for that intubation attempt, no more than 30 seconds, right? So at the time somebody squeezes that bag for the last time and removes the BVM, you have 30 seconds to be ready to go, get everything in there, right? Get that stylet out, holding it in place to reattach that bag and squeeze it, right? 30 seconds. Right? It doesn't have to be fully secured in place, right? We're still holding that tube, but we at least start oxygenating that patient again. Right? We don't want to delay that for too long. Wear gloves, mask, eye protection, right? You're going to be right there, right by that patient's face. Right? You don't want something to come up, splash you right in the face. So these steps, again, go through it, pre-oxygenating, positioning the patient. Again, should be very straightforward. It should really kind of go back to exactly what you guys were practicing in the airway lab, and the steps should be pretty straightforward now that you've got the experience with the equipment. Right? We'll be practicing intubation every day of class. You should be assuming that. All right. Good. The bougie, again, is a great one. Some people use it with the ET tube already on there. Right? But ultimately you're getting the end of that bougie into the trachea, and you'll actually feel the rings of the trachea, right? And say, hey, this is in the trachea, good. Now what you can do is you can just slide that ET tube right down on it, and you know it's going to go straight into the trachea. All right. Don't pass the tube straight down the barrel of the laryngoscope blade. it's just going to block your view, right? You always want to make sure you're kind of coming in so that you can still see the vocal cords, and you're going to watch that tube actually go through the vocal cords. So make sure you're not occluding that space. All right. Inflate the cuff, 5 to 10 milliliters of air. Remove the stylet, hook the bag back up, and start ventilating the patient, right? One of the things that we'll do, right, so we watch the tube go through the vocal cords. We're going to listen to epigastric sounds, right? So putting your stethoscope over the stomach, right? Shouldn't hear anything. If you hear urgling and gurgling every time you ventilate, that tube's likely in the esophagus and it's down to the stomach. So negative epigastric sounds, positive bilateral breath sounds are great. And then thinking about the patient, right? Maybe they were cyanotic, we should expect to see skin signs improve. If they were hypoxic, we should expect to see an increase in SpO2, right? We've got our colorimetric capnography. We've got our waveform capnography, making sure that we're ventilating 35 to 45 for that end-tidal reading with a good, nice, clean waveform each time we're breathing, right? Some people say condensation in the tube, a little bit of moisture. Some places are really starting to back off that one because you can get some moisture coming into the tube even if you're intubated into the esophagus, into the stomach. So the condensation in the tube, a little bit less reliable of an indicator, but again, it's just one piece of the overall equation. All right, esophageal detector device is like a little bulb syringe. So again, it's just understanding that the trachea is rigid tube and the esophagus is flimsy, flexible tissue, right? So if you put that bulb syringe onto the ET tube and it immediately pops back up, opens back up, that means we're in that rigid tube of the trachea, right? If you squeeze that bulb syringe, put it on the ET tube, and it stays compressed down, right? That means because we're creating that little bit of vacuum, that means we're just collapsing that esophageal tissue. We're collapsing it down. That means we've intubated the stomach, right? So if that bulb pops back up, again, we're in the trachea. So that's what it looks like. We had them again on Tuesday. If you have questions about it, Monday, right? Remember, this exam is Tuesday, so if we have any questions on this stuff on Monday, we'll do a little review, but you should really be, kind of dialed in on this stuff. Securing the tube, note the distance, the depth, right? The centimeter marking on the ET tube at the teeth, right? Teeth don't move, right? You don't want to do it to the jaw or some other point that can kind of skew it. And we're going to say it's 23 centimeters at the teeth. Okay? You'll hear people say that. Never let go of that tube until it's fully secured, right? You just don't want it to become dislodged, right? So video laryngoscopes, I'll bring it on Monday. I have one here at the school. I brought it with us, but there's too much other stuff that we were doing on Tuesday with the Airway Lab. I'll bring it on Monday so we can play around with it. But ultimately, it's a little generally disposable blade that has a little camera on the end of it so you can actually see. And so instead of having to get down in there and really take a look at it, we're just looking on the little screen and say, hey, there's the vocal cords. And now you're feeding the tube in, watching it up on the little screen. Sometimes they're attached to the handle. Sometimes they're not attached to the handle. The King Vision, the one on the far right side, is the one that I have that I'll bring with me. Nasotracheal intubation, again, reading through the steps, no head trauma, anything like that. One of the big ones with it, kind of key points to remember, is your patient has to be spontaneously breathing. That's where we get that little orange BAM whistle. And so every time the patient's breathing out, it whistles through there, right? So the patient's got to be spontaneously breathing, which is, a narrow situation in which we have these patients anymore, because we have things like CPAP or we have things like RSI where we can paralyze them. In those situations, it's much less likely that nasotracheal intubation, but it's still fair game. It may be the only situation that you have or the only thing that you have, so you got to do it, right? So reading through it and understanding it. Good. Digital intubation, literally just putting your fingers into their mouth and finding that epiglottis and lifting the epiglottis up and out of the way and trying to feeding the tube into the trachea. It's blind. You're doing it entirely by feel, and I never feel particularly great about shoving my fingers down somebody's throat like that. We don't want to do that if the patient is at all certainly not conscious, but even lightly unconscious, like just really don't do that. Very difficult to do. But you can read through it, you know, some different recommendations on manipulating the tube to kind of help get it down there. And then that's what you do. Dive right in. All right. Transillumination, right, is putting basically a big tube with a giant light bulb into your ET tube. And so if it's dark enough and you see, you know, as you put that tube in, if you see a really, really bright light superficially on the skin, it just means that you're in the trachea and that tube is going to be able to be slid right into the trachea. If it's a very dull light or you don't even see the light, it probably means that tube has gone down the esophagus. So it's just one more way of doing it. I've not seen anybody with it, but yeah, it's just that. It's put that tube in with the big light bulb on the end of it. If it's a really bright light that you can see on the skin or right underneath the skin, again, it's just telling you you're likely in the trachea. All right. All right, so it's the transillumination. Now, retrograde intubation is almost like the reverse of a needle crike, right? We're putting the needle in through the cricothyroid membrane, but then we're feeding a wire up, right? Instead of normally we'd be needling down, we're feeding that wire up, and then you'd pull that wire through, so you got this weird, you know, wire in the mouth and wire through the cricothyroid membrane, right? And then what you could do is you could feed the ET tube over the wire, and that wire, because we put that needle and the wire through the cricothyroid membrane, we know as we feed that in, that wire is just going to guide that ET tube into the trachea to intubate that way. Again, one that we'll pull the cric mannequin out and we could kind of play with the wire to actually demonstrate that. Again, less likely to be used intervention. I've never seen it done, but you know, it could be a potential possibility. Face-to-face intubation or anterior intubation, or the tomahawk method that we're saying, is just kind of reversing everything. Instead of laryngoscope blade in the left hand, tube in the right, come at the patient with the intubation handle in the right hand, tube in the left, and you can intubate that way. Right? Weird to do. You start thinking about like confined space rescues or confined space rescues, and some issues that, you know, maybe just limit your accessibility to get to them. All right, failed intubation. Again, kind of going through these. Again, it happens for sure. The biggest thing is recognize that it was a failed intubation, and then pre-oxygenate the patient, go back to your BLS bagging, and then maybe we try an intubation attempt again. Or maybe we switch over to one of our supraglottic intubation, supraglottic devices like an iGel or a King Airway. All right, tracheobronchial suctioning, which makes sense. Field extubation generally isn't done, right? If a patient starts coming around and fighting us, again, I think I said it in class the other day, if we take the time and effort and everything to intubate the patient, then we should just sedate them and keep them intubated, right? Because if they, you know, deteriorated to this point that they weren't maintaining their own airway in the first place, just because they're waking up now doesn't mean they can't crash again and not be able to maintain their airway. And so we don't want to get into this position where we intubated the patient and then they woke up, so we extubated the patient, and then they deteriorated again, so we had to intubate the patient again. We're not going to keep doing that back and forth, right? All right. So that stuff should make sense. RSI drugs, again, we'll get to them. We have a drug group coming up in a couple weeks that will get into each of these drugs, just understanding different ways to assist us with the intubation process. So reading through these, but ultimately it's our ketamine and etomidate for our sedatives, potentially narcotics, but then really we start looking and we start talking about our paralytics to actually paralyze everything, which is the goal of bypassing a gag reflex, because we're going to paralyze those muscles too. So reading about that stuff, again, I'm not going to emphasize it heavily on the exam, just because we'll get there. We'll get there with our drug profiles for sure. All right. RSI is just that medication-assisted intubation process, so sedating the patient, then paralyzing them.
And one of the big takeaways right now, I'd say, is understand that you should sedate them before you paralyze them. If you paralyze them first, they're completely paralyzed, including their diaphragm is paralyzed. The only muscle that's still working is the heart. They're paralyzed, but they're completely conscious mentally and aware of what's going on and can feel everything. But they can't even move their eyes. We've paralyzed all of those muscles throughout the body. So you want to sedate them first so they don't remember what's going on, and then we'll paralyze them and go down that process. All right. This is going to go through the whole step of it. Supraglottics, again, just understanding the various different supraglottics that we have and understanding that the tip of it rests in the esophagus. So one of the big contraindications for your supraglottics are any sort of esophageal issues. So esophageal cancers, recent esophageal surgeries, esophageal varices. We don't want to put anything in the esophagus that we're worried about causing damage. And the tips of all of our supraglottics will rest in the esophagus. All right, LMAs, right? Look like an eye gel, just LMAs have an inflatable cuff instead of just the gel kind of solidified cuff, but the shape is really the same, and you really just follow the roof of the mouth as it curves down, right? And anytime you pretty much blind insert anything, the end of it's going to go into the esophagus, which is what you can see here, and then when we hook the BVM up and we start bagging, that air is going to come out the front of that and go down towards the trachea. So all your supraglottics are great. They just don't definitively protect against airway aspiration. So even though the tip of it's in the esophagus, if that person vomited, enough of that stuff's still going to work its way around it, and then it can go down into the trachea. All right. There you go. Again, pretty straightforward. Read through all the steps. There's some different shapes ones and different size ones. Some of them you can use and you can feed an ET tube down and you could potentially intubate the patient that way. Some you can't. Right? Eye gels, I think anymore, pretty much everybody is more familiar with these days, but they're great. I never personally used them. We didn't have them when I was out there, but everything I hear is super, super positive with them. And Cobra is one that I've never seen in Arizona, right? But again, National Registry and places don't care about what equipment Arizona carries, right? So they kind of demonstrate and show you all of them, right? So there's Cobra, right? Or Cobra perilaryngeal airway. Just understand it's another supraglottic airway device. Kind of looks like a little King airway. It's made by a different company. Okay. Multi-lumen airways. Those are your old combi tubes, right? And even though we're like, we haven't used a combi tube in freaking forever, they're still out there, right? So you're still responsible for knowing about them and the different size cuffs that are there. So again, make sure that you understand all those requirements. All right, that's all your combi tube. All right, so surgical and non-surgical cracks, so surgical and needle cracks. Again, we're inserting and accessing straight through that cricothyroid membrane. Some of them have very formally, built cric kits, which are great, right? You can use that to actually put that part directly into that. Take your syringe off, pull that needle out, and you can bag right away, right? So super fast, comparatively. Otherwise, you get the scalpel out, and you can just cut through the tissue, open it up, and feed a regular ET tube down in there. Just some of them have the commercial manufactured cric kits. Indications, again, severe upper foreign body airway obstructions, massive maxillofacial trauma, inability to open the mouth, right? BLS bagging's not working, we can't intubate, maybe we tried a supraglottic, but not with that facial trauma, sorry. We're not gonna do the supraglottic. So we can't intubate, maybe we tried, we keep failing, BLS bagging's not working, where they're continuing to bleed into their oropharynx. We have to control that airway, right? We never move past A until we get that one ready to go. So really understanding what are our advantages and disadvantages, what are indications and contraindications, right? What are the complications of it, right? Going through and understanding all this stuff. Again, hopefully when you read this section, you're like, yeah, cool, that's what we were really talked about in the airway lab. Right? Ooh. All right, So again, just get a cuffed 6.0 ET tube, right? Or you actually get a tracheostomy tube if you're carrying those, or you have an actual pre-made kind of crike kit that has their own little device in there. For needle crike, you really need one of those jet ventilators if you got one, right? It's such a small little tube that we're going to try to ventilate through that we need something to really get a high pressure air in to actually be able to get any sort of real air pressure down into the lungs to get the oxygen into the body. All right, so not a great method, but maybe that's one of the only issues or only access means that we actually have. All right. So again, going through that, I know Matt Stone was saying it the other day, but again, 45-degree angle, angled towards the feet, right? We're not going straight in with an IV catheter and trying to bend it, right? We don't want to go up, right? We're not ventilating that way. So 45-degree angle, feel through the pop, and then we're ventilating down towards the lungs. All right. Oops. Sorry, so that is actually the end of the slide there, guys. So the big thing with this chapter, again, procedural stuff, airway anatomy and physiology stuff that's in this chapter that is also from your chapter 8, going through it, but really just understanding the steps of all these different interventions, what are the indications and contraindications for the interventions, the equipment that you need, how to do it, and why we're doing it, right? The BLS stuff's not working, so we're going to move to the ALS interventions. I'm going to get this up right now, posted for you guys, and I'll send you some more emails with some stuff, right? I'm building a new test for us, so the stuff that I lecture is exactly the stuff that I'm going to be kind of putting on there. But remember, read, right? Reading comprehension, right? So I'm going to send you guys some more information and kind of talk about it. But airway management is 50% of our exam, right? That's just how important it is. It's a 200 question test. I did exactly 50 questions from this chapter. So definitely make sure you got a good grasp of this one. So I'll talk to you soon, guys.